individuals who are passionate and dedicated for the cause of family medicine. So AFPA is actively promoting the specialty of family medicine. We have had a remarkable journey, I would say. AFPA started in the year 2010. In 2010 we had about 36 members in that year, and it has grown to more than 2,000 members today. And we have members from each and every state of India. So I think we've had a remarkable journey. We have about 13, now the 14 state chapters of AFPA. Education and capacity building being the core objective of AFPA. So in this direction, I think AFPA is doing a good job. We are having academic activities to meet the needs of primary care physicians on a regular basis through various wings of AFPA. We have a young doctors wing called Spice Route Movement. We have a CPD wing. We have the special interest group. So far we have conducted about 5 national conferences, many state conferences, and other workshops, exchange programs are an ongoing process. And through this, I think AFPA has fostered a culture of I would say lifelong learning, or a continuous learning of professional development, knowledge sharing, and looking at the future, I think we would like to continue this journey, and I would request those who are already not, how many of you are AFP members? Can you raise your hand? Okay, so there are still people who are not the member of AFP, so I would request you to go through our website. The website is here, and know more about AFPA, what we are doing. One notable achievement for AFPA is that we have been able to establish a network of qualified family physicians, and through this network we are connected to each other, and we have been able to bring in a sense of belongingness among the family physicians. Also, we are involved in the advocacy to the policymakers, and I think through our advocacy, I would say it's an achievement for AFPA that we have been able to establish family medicine as a distinct specialty in our country. So today we have 6 medical colleges running MD program. We have 200 plus DMB seats every year in family medicine, and recently we got 500 diploma seats released through NEET. So these are all some of our, I would say, the outcome of our advocacy. In addition to just education, we are focusing on the primary care research. So we have our own journal called Journal of Family Medicine and Primary Care, JFMPC, and it is peer-reviewed journal, indexed by PubMed. This gives an opportunity for primary care physicians to publish their papers and their research work in primary care. Karnataka state chapter is one of the most active state chapters, I would say, along with Kerala, Telangana and all. So we have nurtured many of the Karnataka members who have grown as national leaders. We have Dr. R.K. Prasad, who is the current state president and also heads the research wing of AFPA. Dr. Jyotika, the national secretary of Spice Route Movement. We have Dr. Soumya, Dr. Anupama, Dr. Roshni, who is heading the CPD, Dr. Suprita, and Dr. B.C. Rao. He don't mention. So, I was just telling that RxDx is special to AFPA Karnataka because this is where exactly this whole idea of Karnataka state chapter emerged. Although we had a meeting earlier, but this is where I met our mentor, Dr. B.C. Rao. Dr. Jayavaj is not here. I think we had a meeting and we discussed how we can form the state chapter and how we can take this journey. And rest has been a history. 2014, I think, I was here in RxDx. So thank you so much for this opportunity, and I would request please interact with these leaders. We have Dr. Ravi from Mysore. He was the treasurer of Dr. Shalini, of course, she is the scientific chair. So why I am taking all these names is because these are the same people who are like you, and now they've grown as leaders of family medicine in the country. So there's a huge opportunity for you to grow as family physician, grow as a leader. So please interact with them, create a network. They by themselves are a huge resource. So please do join AFPA. Thank you.
Lack of opportunities for good family doctors to build a community practice. And that's actually how 15 years ago we started RxDx with that vision to be primary care led. So we're not a hospital, but it's really a pre-hospital. And I think, listening to Dr. Mohan about the journey of AFPI, Dr. Rao asked me to talk a little bit about entrepreneurship. And I think entrepreneurship is essentially about that, about finding a need that's unmet, about then meeting that need, and about doing that for a very, very long time. And I think today, in the day where healthcare entrepreneurship is about PE funding and rapid rise and rapid falls, sometimes as physicians we get a little bit of FOMO, fear of missing out on this big wave. But I would say, in my experience, doing something consistently for a long time and believing in it is really the crux of entrepreneurship. Phygital ones, which are a mix of physical and digital, and then about 40 rural digital centers. And I think that is also something that as physicians, I think it keeps us motivated to be able to do for the communities around us and to be able to take our knowledge as far as we can. And I think that is what Phygital has today enabled, that combination of telemedicine and on-site. But anyway, thank you for having me, and I think I'm here to learn as well. I'm as confused about adult vaccines as everybody else is, but pleasure hosting you this morning.
Thank you, Dr. Sunita. It's brief and quite inspirational journey of RxDx and a brief explanation about it. Thank you so much. So let's start the show. So the first topic of today's session is the new kid in the vaccine basket, that is herpes zoster vaccine. So to talk about this topic, I would like to invite Dr. Belliyappa, a healthcare professional with 33 years of experience, ranging from a short stint of 5 years in the Indian Air Force, foreign tenure at Muscat, Oman, and experience in primary care with 2 startups, presently working as CMO at RxDx Healthcare since the past 16 years. He is also associated with Unilever as a part-time consultant physician. He is passionate about primary care and keen to learn about recent trends and trending technologies in the primary care space. I invite Dr. Belliyappa onto the stage, and I would like to invite Dr. Mohan Kupindra to come and share the session.
I thought as a chairperson I will have the pleasure of introducing Belliyappa, but I think she took away this thing. So I just want to say Belliyappa is my old friend. We were commissioned to Armed Forces at Belgaum in the year 1991. Although he served for he had a short stint in Air Force and moved on, but I stayed on. So we have fond memories of firing the guns and doing battle physical efficiency test in medical officer basic course. We go through a rigorous 2 months training just before we are inducted into Armed Forces. Even as doctors, we are given the military training. So we both were postmates. I just want to say that it's such a pleasure to be sharing the stage with Belliyappa.
As you become adults, the vaccinations are good, the immune system is good, and then it gradually comes down as you age. So that's when a sensation of immunosenescence, and that's when you need to take the vaccines again. So we know that you get chicken pox, and after chicken pox, the virus will remain in the dorsal root ganglia and then gets reactivated. We are not too sure how this happens, but it could be stress and strain is one of the things which is said that it's possible cause for the resurfacing of the virus. So as you know that herpes, you can have a prodromal phase, and then after that you could have headache, photophobia, then you could have the classical rash. It usually affects from T3 to L3. I don't know why, but this is a common area. It could have multiple dermatomes, and sometimes it can affect the, you can have zoster ophthalmicus or the Ramsay-Hunt syndrome where the ear gets affected. And then you can have a subacute phase for 3 months, and then some people can go on to have post-herpetic neuralgia. Shingles, I never knew it was so painful till my mother got shingles, and she really suffered for about 6 months. Then I realized how bad it can be, burning, stabbing, because patients, you just see them for 5 minutes and you don't see them for months together. So if you can see that both herpes zoster and the post-herpetic neuralgia, it's very close to, it's actually above the labor pain. So it's quite painful. Only a person who has an infection can tell how bad the pain is. And it can also affect your activities of daily living. So you can have a condition, actually I learned on this condition only after reading this presentation. It's called zoster sign herpeta, where you have pain but no rashes. It can happen in the face, it can have it happen in the mucosa, auditory canal, unexplained abdominal pain, which could be possibly zoster. So as physicians, we should consider this also as one of the causes. So if you get infection, chickenpox, and then as you become an adult, you reach the shingles threshold, but because you're having this immunity and the exposure and the silent reactivation which takes place, the chances of you getting it are not there. But as you become older, if you're immunocompromised or beyond 50, again there is a decline in immunity, and that's when you can have the herpes zoster. So you can see across countries, as you become older, the chances of herpes zoster are higher. Overall rates can vary from 3 to 5%, and as you can see, as you become older, the rates keep going up. And the risk of developing post-herpetic neuralgia is about 5 to 30%. Indian studies, more than 50 years, 15 to 81%, and post-herpetic neuralgia from 10 to 54%. So as you can see, it can coexist with other diseases like diabetes, kidney disease. The chances are higher with stress and also trauma. Post-herpetic neuralgia can also affect the herpes zoster ophthalmicus, where the eye is affected, and other complications like cardiovascular, hearing loss, scarring, and cranial involvement. Immunocompromise is one thing. If anybody has more than one dermatome, you need to investigate if there's an immunocompromised case like HIV or otherwise. And you can see the highest is in the hematopoietic stem cell transplant, and it can occur in all other diseases too. And the age-wise risk can occur in all types of diseases, and the difference between 50 to 59, 60 to 64, 65 is not very much. The treatment, what we're looking at is, we need to initiate treatment within 72 hours. We are now giving there's acyclovir or valsiclovir. Valsiclovir running 3 times a day, which is quite easy to take compared to acyclovir, which is 5 times, and the patient compliance may not be that great. And once the treatment is initiated, then we give the treatment for about 7 days. And then after 7 days, once the rashes come down, then you might have post-herpetic neuralgia. For this, we use different combinations, tricycle antidepressants, topical agents, and painkillers. Now coming to the vaccine, it's a non-live vaccine. It's got 2 components. It's an antigen and an adjuvant system. So you have a powder, you take the fluid and put it in the powder, mix it together, it comes about 0.5 ml, and then you have to inject into the deltoid region. When the injection is given, there is no pain, so take my this thing, but after that, you will have a little bit of pain. So the adjuvant system enhances the immune response. So this is a scenario where without the adjuvant, and here you have a stronger immune response with the adjuvant. So that's the advantage of having an adjuvant system. This is a study which is done in two categories of people, those over 50 and over 70, and the vaccine or placebo was administered to at 0 and 2 months. And you can see the statistics all very good. In the 50 year, all 90 plus, and 50 and 70 years, also 90 plus. So it's good protection. Of course, like any vaccine, no vaccine can be 100%. If you read the posology which I have in my pocket, it says the same thing. No vaccine can be 100%. So that we need to explain to a patient, because patients sometimes expect that they may not get it. We have seen breakthrough with chickenpox vaccine too. It reduces both post-herpetic neuralgia as well as the vaccine efficacy is very, very high. Skip this, and then you can see it can be given for very many medical conditions, ranging from hypertension to diabetes, which are common and quite rampant in our country. Adverse effects, you can have pain, redness and swelling. These are local, and also you can have fatigue, fever, headache, myalgia or shivering. And these are some of the studies which are done in various cases. I will not go through this. Hematologic malignancies would help. Then hematopoietic stem cell transplant, renal transplant, and HIV infected subjects. So like I said, vaccine is given as a 2-dose series, 0 followed by after 2 months. If you're not able to give in 2 months, you can do it in 2 to 6 months, but ideally 2 months. Supplied as 2 vials per reconstitution. It should not be, it should be refrigerated, but do not freeze it. And only for intramuscular, no intradermal or subcutaneous. And it doesn't prevent chickenpox. That's very important. A lot of patients will ask this question. Can it be given in other vaccines? Yes. Influenza, pneumococcal and Tdap, it can be given in all of them. No safety issue have been raised. And global bodies from the CDC to other, all global bodies have recommended for asthma, COPD, diabetes, and above 50 years. For rheumatoid arthritis and for psoriasis. So safety, pain at the site, myalgia, fatigue and headache, but they're not very long lasting when they lasted for 1 or 2 days. Yeah, thank you. So if there are any questions, please feel free to ask any suggestions or comments.
So Dr. Bedi, everyone over 50 is recommended? Is that
Yes, everyone over 50. Now that's a trade-off, because many patients say it costs money. So it costs about 10,000 rupees a vaccine. So, but to prevent post-herpetic neuralgia, which can be very traumatic and very painful, the choice is there. You know, the decision is up to the patient. And I've taken it, so I would recommend who's anybody above 50 to take it. It would definitely prevent post-herpetic neuralgia and the herpes, which can both are very painful conditions. Of course, there's a cost involved, so that we have to explain. But then many patients say, if I spend 20,000 rupees, I can treat myself for cheaper. So that is some of the things you need to.
painful?
So some of the.
Yeah, that is the question actually. As general practitioners, should we recommend this to the entire population above 50 years, considering the cost for just a painful, debilitating condition, not a life-threatening condition? So, should we recommend this to across the thing or only to?
But it can cost. The question is, I see the flu vaccine is a good point indicator. I never took flu vaccines till the H1N1 came. From that time, I've been taking flu vaccines, and my cough and colds are much better. So I think it depends on how people do not keep money for primary care or preventive care. So I think people need to budget, they need to spend a little bit of money for prevention. So I think that's the future. Prevention is going to be the future. How much we are able to convince them that they should take vaccines to prevent these, like you said, they're not life-threatening, but it can be very irritating and painful.
Can we at least probably say that for comorbids, we should probably educate them.
Yeah.
At least, diabetics and probably the dialysis patients and.
But Dr. B.C. Rao, sir, I'm not here because you have been in the group also. This discussion was there. I think you were strongly recommending that it should be offered.
I think, Doc, you have covered most of aspects of this. But one thing is a bit contentious is extreme old age, when the immunity levels are very low and immune response is also very low. Is it worth giving? I saw that slide of yours which says it is, but still there have been some doubts as to is it really useful to give this vaccine in the extreme old age when there is a very severe immunocompromise. They don't respond at all. There is no immune response at all. They don't produce antibodies. So is it worth giving?
Yeah, that's a very valid question. Now, for immunocompromised, there's some of the cases in elderly age group, they're not told very specifically. But if you're taking steroids less than 20, or you're taking methotrexate 0.3 milligram per kg body weight, or azothraglobin, or the monoclonal antibodies, you can give it in immunocompromised cases.
Some response is better than no response.
I think Dr. R.K., who is an expert HIV specialist, should comment on immunocompromised state and Shingrix or other vaccines.
Of them developing an infection because of the vaccination. So I think comes down to economics, but if someone is well controlled and can afford, I definitely think they should be offered.
Thank you, sir.
Exercise module. So where she, I think the immunity was low, she got shingles on the tip of the nose, for which she was treated. After 6 to 7 months, she had again another episode of shingles in the same place, and again treated for the same reason. And her question was like, I think she is also aware of, when you read about it in the net, she was like, shall I take this vaccine? Do we give vaccine after 2 episodes? What should be your advice for someone like this?
The vaccine can be taken once the acute phase is over. That means it's dried up and there's no eruptions and no discharge and all that. If there's a little bit pain, it can be given. So ideally, in a condition where there are 2 vaccines, you should be given.
Sir, you say that it is a reactivation of chickenpox.
Yeah.
I never had chickenpox.
Yeah.
So should I take this vaccine? She says, I don't remember having had chickenpox. So there is a chance of recurrence. That is why it is recommended that.
But your question is very valid. I've seen most patients of herpes not getting attacks so far. Most patients, I have not seen that. But I have not seen so far. Thank you.
Thank you, Dr. Paediatric. So let's move on to the next session on HPV vaccine. I would like to invite Dr. Vijaya, a physician with about 20 years of experience, started off with a brief stint in emergency medicine, followed by hospitalist experience in the US, currently working in primary care as an internist for about 10 years. I welcome Dr. Vijaya to talk about HPV vaccines.
Good morning all, thank you for coming today. So I have a few slides regarding the HPV vaccines. It causes oropharyngeal cancer. A lot of oropharyngeal cancer in men. The incidence is higher in men, HPV virus. So there are 2 types of viruses, the low risk HPV and the high risk HPV. High risk HPV can cause cancers. Men, a lot of oropharyngeal cancers. And then women, we see the cervical cancer. Then there's also anal cancer, we see the vulvar cancer, penile cancers and the genital warts. So why is cervical cancer is important? The cancer burden is very high in India, and in Indian women, 1 in 50 will develop cervical cancer in their lifetime. It's the 2nd most prevalent cancer among women in India, behind the breast cancer. And 67,477 women die every year from cervical cancer as a result of late diagnosis. So cervical cancer can creep up on women, and by the time they detect, it's going to be late. So it carries a high mortality. So we need to attack and try to find preventive strategies. And how do we do it? So here there's a little bit of confusion, so we have to look at this very carefully. Important thing is to get regular checkups. number one, and then we have the HPV vaccination. Third one is pap smear. So I'll dwell on this point a little bit. So it's not to be, so these things are separate. The vaccination is separate, pap smears are separate. The recommendation is that all women starting at the age of 21 years, they have to get the pap smears on a yearly basis, up to the age of 63 years. So there's this HPV DNA, a new thing has come up. We can find out HPV DNA in the analysis of the microscopic analysis. If we have this, then once in 5 years, testing is enough. No need for yearly pap smears. So this is on one side. So when we do the pap smears, we can find out if there is any changes at the cellular level, whether there is any dysplastic changes, whether the woman is going to have cervical cancers or pre-cancer lesion later on. So this is on the one hand. And the vaccination is a separate strategy in itself. Again we go here, cervical, so the idea, why do we vaccinate? So we are vaccinating, we are targeting a population who are not sexually active. So they chose children above 9 years. So ideal age would be 11 to 12 years in the Western population where the sexual activity happens earlier. In the Indian scenario, it will be up to 14 years, 9 to 14 years. So we are targeting a population who are not yet exposed to the HPV virus, not yet sexually active, because how does the virus come? Mostly due to penetrative sex. So this is the way the HPV is actually transmitted. So there's no point, there is efficacy but less effect once the once the person is already sexually active. So these are the plans for prevention. So what type of cervical cancer vaccines we have? So the first one that came out was a bivalent cervical vaccine. That was a Cervarix. It costs about 2,000 to 3,000 rupees and it is targeting 16 and 18. So as we discussed, there is these 70% of the cancers, cervical cancer is caused by serotype 16 and 18 and Cervarix covers that. Next one that became available was the Gardasil. This is quadrivalent. So this covers 16 and 18 as well as 6 and 11. 6 and 11 covers the anal warts. The last one is Gardasil 9. So this is the 9-valent. The 9-valent covers 16 and 18, which is covering 70% of the cancers. So its light is not good. So we had the 16 and 18 already covered. In addition, 6 and 11 that covers the anogenital warts. Plus we have 5 more. That is 31, 33, 45, 52 and 58. So this will be about 90 to 100% coverage of all the powerful HPV serotypes that can cause the cancers. How many doses? So what is recommended right now is before the 15th birthday, 2 doses, 6 months apart. And once the 15th birthday is crossed, it will be 3 doses. So if it is Cervarix, it will be 0, 1 and 6 months apart. And if it is Gardasil, it will be 0, 2 and then 6 months. And basically the cervical cancer is a very important cancer for women. It stands about 4th or 5th on the global scale cancers for women. So we want to vaccinate as many women as possible. As you all know, it is a little bit of on the more expensive side, at least 3,000. The cervical 9, the Gardasil 9 costs 10,000 rupees. So this is what is the budget for us. But in some countries like Africa and others, they are not able to afford. So the strategic advisory group of experts on immunization, what they call as a SAGE, they recommend that at least one vaccination should be good enough. It has a very high efficacy of up to 98%. And so they are saying before the 15th year, 1 or 2 doses, at least 1. And after 15 years also, 1 dose minimum should be sufficient to bring down the incidence of cervical cancer across the globe. What are the contraindications? Like any vaccinations, you have to ask if they have, like for the flu vaccine, you have to ask if they have any egg allergy. So for cervical cancer, we have to ask, make sure that they don't have any yeast allergy for Gardasil or Gardasil 9 and make sure that they are not pregnant. And what is the target population? Target population is all girls and boys aged 11 to 12 years of age. It can start by 9 years. So one may ask, even I'm curious why the boys need to be vaccinated. So it's got many benefits. So among the boys, the oropharyngeal cancer is more. And there's no way to identify the oropharyngeal cancer. There's no screening program unlike the cervical cancers. So these the HPV vaccine brings down the oropharyngeal cancers in men. And also there's a herd immunity. Once we bring down the HPV among the boys, the girls also, the incidence of the cancers and HPV induced lesions in the women also will come down. So there's a cross coverage. And of course the anogenital warts across the sexes, the HPV vaccine has protection from the anogenital warts. So the next group will be the teens and young adults up to age 26 years also we can give. And in India we give to all the women up to the age of 45 years, even though they might have had, obviously they are in a sexual relationship and they have been exposed to the HPV virus, but still whichever works. Two more causes for HPV are immunosuppression, of all types of immunosuppressions, and smoking.
Hello. Vijay, this is Anupama here. Just wanted to check, my doctor herself has egg allergy. So we are going to get some nanovalent vaccine very shortly is what I heard, which is going to be against egg allergy. So I was just waiting for that vaccine, but can I give Gardasil 9 now with some
only for yeast allergy. You can give, if they have egg allergy, you can take it.
Nothing like that. Because you mentioned egg allergy, so I was just...
I just compared it to the flu.
Is there any difference in the side effect profile of the allergy between the three vaccines?
Not that I know. So they don't two vaccines.
Egg allergy is not a contraindication.
Not a contraindication.
Any other questions?
One vaccine, I think we all should vaccination. All the other vaccines.
Can you speak how many percentage of the cervical cancers are due to HPV and what other viruses?
Sorry.
How many percentage
of cervical cancers are due to HPV?
70 to 90%.
So other 30%?
So smoking, various other reasons.
Yeah. And do you have to make an give the children an informed decision to make to take this vaccine and make them take this as an opportunity to get education?
So I think up to 18 years, the parents can make informed, take some consent for the children, and then post 18. So that is the standard cutoff. 18 years is a cutoff. So the parents can take a decision for their children. And most of even though the cost is prohibitive, I'm seeing that a lot of people are interested in giving the HPV vaccine to the kids. Even though it is costing 10,000, I gave to my daughter 2 days ago 10,000.
There's a plan
and
to bring in the
impact of vaccination on the
Yes.
prevalence of cervical.
Yes. It is 100%, 99 to 100% effective.
In patients who are polygamous, that the incidence of HPV is more.
Yes, it's more.
Absolutely.
It is more, yeah.
There's a plan to bring it into the universal immunization program. Do you have any idea where it stands? They were saying by middle of this coming year they will be bringing it in.
Gurmeet would be able to give an answer for that.
So when you saying universal program is for India, you talking about? Yeah. I think they already have it.
No, it's not the IAP.
It's not the IAP program. It's the
as long as the
IAP.
cost is not come down, I don't think.
The cost will be around 500 rupees, and it is going to launch.
I think Bharat Serum has taken up this. They're saying that it will come down to 500%.
I have been asking my patients to defer it for about 5 to 6 months, if possible, so that they get the benefit of.
There was a statement by the Bharat Serum.
Serum Institute. Correct.
Just like the BCG.
Quadrivalent is good enough.
Some protection then.
So even bivalent is good enough. If you look at that, it's not.
Now, surveillance, is it still still available or Servavac has come, right? Servavac.
It's not available. Distributors are not getting it.
Cervarix is not
available.
Servavac.
Someone has taken Cervarix and they want to now take Gardasil. We have to give again 2 doses of Gardasil.
We have Servavac. I think that's also quadrivalent, right? From Serum Institute. Servavac is available. CERVAC. It's there. Yeah, it's there. Servavac. It's around 2 to 3 days.
The other
So
thing
the
I
important point Dr. Shalini made is that if you have taken 1 dose of Cervarix, you have to repeat in case if you are switching to 9 labs. So you have to repeat the whole schedule.
Yeah, that's true.
One thing I wanted to add is, like we were saying, how do we convince the patients? So we have had these parents coming up whose children are going abroad to study. So that group is also very aware of it, and we can use that awareness to spread it for them.
So now that this point of awareness come, I think I am proposing and requesting the organizers, can we offer this same presentation to the community? Same panel, maybe we can have a community awareness program on all these vaccines, especially the HPV vaccine. From AFP, I think
we can have
maybe a kind of webinar, because it's very important to create awareness about this vaccine.
Yeah, unless we show conviction in our counseling, they will never be convinced. That with HPV, I've always found that difficulty.
Shalini, I think we can have one webinar for the
Yeah, I want to ask something. Most of the patients who come and we advise this Gardasil oil, the thing is, all of them tell me this causes infertility. So what do you do?
So there is such a talk. There was a talk they were saying that the tubes are going to be blocked by the vaccine. Yeah. But they have done several tests and they're saying that there is no such truth to that particular.
Yeah, but if there is some, article or something, it will be helpful for all of us.
Yeah, there is. I went to yesterday, somebody mentioned that.
Yeah.
But
it's very important because most of them are refusing with that.
Yes, it is true. A lot of people think that it causes infertility, but there's no truth to that. And they have done studies, and there's an evidence-based proof to say that it doesn't cause any kind of tubal blockade. If only this vaccine is going to be helpful. If people have, I've seen patients with cervical cancer when I was doing my internship during Bangalore in BMC, and I've seen these women suffering, and it is a terrible thing to go through cervical cancer. So once you see that kind of suffering, you'll be fully convinced that this vaccine is only here to help people reduce the number of deaths. It's only going to do good to the women. It's a good thing.
Adding to your point, Dr. Leena, I heard not only for cervical cancer vaccine, but also for all the vaccines. I heard recently one of my patients saying, I don't want to take the vaccine because I heard WHO is adding something to the vaccine to reduce the population control. So these kind of myths. I had argued for 1 hour, but still he has not changed his mind.
Even for the COVID vaccine, they are saying the same thing.
It causes infertility. One of the
Thank you, Dr. Vijay, and all of you for actually participating in the session. I would like to invite Dr. Subramanian to present the token of appreciation for our speakers and chairperson. Welcome, Dr. Subramanian. Dr. Subramanian is senior family physician practicing over 45 years, and he is an advisor to FDA Paediatric. Welcome, Dr. Mohan. Dr. Subramanian to present the token of appreciation to Dr. Mohan.
How many years of age one gets the title of senior?
Welcome Dr. Beliappa and Dr. Vijaya. Thanks, Dr. Subramanian, and thanks all the speakers and Dr. Mohan for sharing the session. Moving on to the next session, next topic.
Children as well as women, primarily. So that is the whole idea behind NIP. So when I talk about NIP, So it was launched in the year 1985 as Universal Immunization Program. It's known in the world as one of the most cost-effective as well as one of the largest public health programs in the world. So I think we really have to give it to our government for rolling out this program and taking it to the next level at every possible opportunity. So what have been the achievements of National Immunization Program so far? When it comes to deaths, generally speaking, around the world, at least 2 to 3 million deaths are prevented every year by the National Immunization Program. So when I talk about this deaths, I'm talking about NIPs in most of the countries. When it comes to India, we are talking about prevention of under 5 deaths. The under 5 mortality has been brought down from 3.4 million to 1.2 million between 1990 to 2015. That is the achievement. And most importantly, the disease burden, the mortality of people due to measles has been brought about by at least 75%, has decreased by over 75% in the last 20 years. That is another achievement of National Immunization Program. So what are we trying to achieve with National Immunization Program? We are achieving good immunization, vaccination against 12 diseases nationally and about 3 diseases subnationally. So when I say nationally, these are universal, that is the DPT, the MR, polio, severe tuberculosis, hepatitis B, meningitis caused by hip, and pneumonia caused by hip. So these are mainly the primarily which are used as prevention for all over the country. But in some pockets of the country now they have introduced the rotavirus vaccine as well as pneumococcal, and of course Japanese encephalitis vaccine has been there and it's still promoted in the endemic areas. What have been the major milestones of the NIP? One is elimination of polio. We are all aware from 2014 onwards polio has been eliminated, and as on 2015 neonatal and maternal tetanus elimination. These have been the major milestones in NIP. Another thing I wanted to throw light on was Mission Indradhanush, which was launched in 2014 by the Government of India to achieve at least 90% coverage of immunization and vaccination. So in the first 2 phases, it is found to have increased the coverage by about 6.7%, whereas in 2016, they launched the Mission Indradhanush Intensified Mission 2.0. So that has achieved about 18.6% increase in the coverage. But thereafter, COVID has been a dampener, so I think a lot of things suffered under that. The vaccination took a major hit during COVID times, but then slowly now they want to intensify this Mission Indradhanush. So when we talk about rolling out a vaccine under National Health Mission, there are a few steps people follow. So I just wanted to quickly run through that. One is they first assess the disease burden, and then they see the safety and efficacy of the vaccine, affordability, financial sustainability, and then the program capacity, how long it can sustain, and availability of domestic and external vaccine production capacity. So you can imagine all this was done at a very fast pace during COVID times. So generally people are quick to ask questions about the efficacy, safety, everything about COVID vaccines, but all these steps were really catalyzed, and then the vaccines were rolled out. So I think at that point in time, were we actually thinking of the long-term effects? Were we able to foresee that this might be a problem? But then surviving the pandemic was of utmost importance rather than looking at the long-term efficacy at that time. I mean, that's my understanding. So I would like to hear from you at an appropriate time. What do you think about it? So now coming to the vaccines, the national immunization schedule according to age. So we are all aware of this. Just wanted to quickly run through. and then discuss it. As opposed to private practitioners, we have vaccines available on the IAP schedule as well. So we'll draw quick comparisons on that. So the first thing, at birth we are giving the BCG, the 0 dose of OPV and hepatitis B, the birth dose. And at 6 weeks we give the OPV1, pentavalent has your DPT, Hib and hepatitis B. Then you have rotavirus, the fractional dose of IPV, and then the pneumococcal conjugate vaccine. So the pneumococcal conjugate vaccine has been introduced in few states. Now they are going to take it up further. They want to have a pan-India availability of PCV. So the difference again, I just want to draw a small difference here. PCV is given 3 doses at 6 weeks, 10 weeks and 14 weeks as per the IAP schedule. Whereas in the National Immunization Program, we give 2 doses at 6 weeks and 10 weeks. And the practical difficulty here, as I've seen with my patients, somebody who has started their vaccination with the government, they get the PCV over there. But if we have the patient has received PCV outside somewhere, and then he goes back to the government to get the next dose, I am told that government is not, the government centers are not encouraging that. So I would like to know more about it from you all as practitioners in this point. Okay. So we get 2 doses as per National Immunization Schedule. PCV is 2 doses. And then at 10 weeks again pentavalent, 2nd dose of OPV and rotavirus vaccine. And then at 14 weeks we have the 3rd dose of OPV, pentavalent, again fractional dose of IPV, as well as rotavirus vaccine and PCV2. At 9 to 12 months, government recommends MR, that is measles and rubella vaccine, Japanese encephalitis 1st dose, as well as a booster for PCV. Between 16 to 24 months, we have the 2nd dose of MR, Japanese encephalitis 2nd dose, and the DPT 1st booster as well as a OPV booster. Between 5 to 6 years, we have DPT 2nd booster, and then 10th year, we have the TD vaccine, that is the tetanus and adult diphtheria vaccine, and 16th year, the same thing gets repeated. Now, for the pregnant mother, we have the TD1 and TD2 or TD booster. So this is in short about the National Immunization Schedule as it is given. So there are times when we are faced with certain questions from our patients. They say, what is the upper age limit to which you can give a vaccine? Like a 15-year-old comes and asks for BCG? No, he's not eligible for BCG because BCG is basically for prevention of severe forms of tuberculosis. That is another awareness we have to give our patients. BCG doesn't prevent TB, but it prevents from the severe forms of TB like TB meningitis and miliary tuberculosis. So up to the age of 1 year is when you would give BCG. Beyond that, they are not eligible. Another thing is MR, that is measles and rubella. Up to the age of 5 years, you can give 2 doses. Thereafter, it's generally not recommended. But whenever there is a school program for 9 to 15-year-olds, wherever there is an MR campaign, at that time they are eligible for the vaccine. Anywhere between 9 months to 15 years, 1 dose of MR definitely makes sense because rubella has a propensity to strike at the wrong time, causing devastating effects on the fetus. So MR, please recommend whenever there is an MR campaign. The third thing is OPV. Up to the age of 5 years, oral polio vaccine. Beyond that, no OPV. DPT, up to the age of 7 years. DPT, please remember, up to the age of 7 years. Beyond that, it's always TDAP, that is your Boostrix. Before that, only is DPT. So, we don't give wholesale pertussis vaccine beyond the age of 7 years for the fear of neurological effects. Beyond the age of 7 years, it's always TDAP, Boostrix or your TD. And then Japanese encephalitis vaccine can be given up to the age of 15 years. However, personally I recommend it to patients who are in the endemic areas. I would like to know more about our recommendations from experienced pediatricians here, and Madam of course will throw some light on that. And if these vaccines, that is IPV, PCV, pentavalent and rotavirus vaccines. If they are not given in the first year of age, then they cannot be administered to a child under the universal immunization program. For example, a 5-year-old comes for a rotavirus vaccine, I am not going to give him that. He's well past the age of where he will have rotaviral diarrhea. He may have, but then the sensitive age group is crossed, so I wouldn't really recommend. It's always important to maintain a uniformity, to understand how many, to get feedback from parents as to what vaccines have been given. Many a time what happens in the government sector, the parents are not told what vaccines have been given. They're just taken like a herd of cattle, chuck, 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 vaccines are given and they're sent away. So when you take a feedback, if they have taken in the government of India, they have made a, they have brought about a uniformity on what vaccine should be given at what site, so that we can get a feedback from the parent whether certain vaccines have been covered. So in this, when we say oral, we are talking about OPV, rotavirus vaccine, and vitamin A. So these things we can ask them at what months it was given and we can get a feedback. So when I am talking about the upper right arm, the fraction dose of IPV as well as MR. So the IPV is given intradermal and MR is given subcutaneous on the right upper arm. In the left upper arm is BCG as well as Japanese encephalitis, again intradermal and subcutaneous respectively. Then when I talk about the right anterolateral thigh, I am talking about the PCV vaccine. And the left, it's always DPT, pentavalent, as well as your hepatitis B birth dose. These are given on the left side. So this is a comprehensive table which includes the dose, the route, the site, when to give. So this is easy to follow. So again, when we are in doubt as to what can be administered along with what at 6, 10 and 14 weeks, these are the vaccines that need to be given. So what are the key messages you want to give a parent? Because most of us get patients who are quite well informed about vaccines, but these are certain things which I always tell my patients when they come in. What vaccine I am giving and how many doses I am going to give of the same vaccine. This minor adverse effects that they might have. The next visit date, how many more vaccines are left behind so that you don't lose them to follow up. Maintaining the immunization card is of utmost importance. I always tell my patients because nowadays with many students going abroad, they are all asked for the vaccination card. During transit or some movement, most of the parents lose their immunization cards. So they come back and then it's a big problem too. I've even got the antibody levels done to check if vaccines have been given, not given, all those things. So you can always insist with the parents that please maintain the vaccine cards. And then also, because the post-vaccination, wait for 15 to 20 minutes at the site so that if there are any adverse effects, you can pick it up. So yeah, that's more or less about the national immunization schedule. Just quickly draw a comparison between the IAP as well as NIP. So once we are clear about the NIP, what is given, what is not given, based on that we can recommend whatever vaccines that need to be given at an IAP level. Two vaccines which I very strongly recommend is typhoid and chickenpox, simply because typhoid, the disease itself takes about a week to diagnose. The morbidity is too much. Virtually the patient loses the entire month fighting the problem. So typhoid is definitely what I recommend. And even for people who are not able to afford that much, I encourage them to go for the vaccine at some point in time because they suffer a lot. And second thing is chickenpox vaccine. I always push for it at an earlier age. If they have not received at an earlier age, like 1 year, 3 months, or even 3 months after that, if they are around 9 years, 10 years, I definitely push for it because I think as a practitioner I've seen as age advances the severity increases. There are many kids who recover with minor infections and they get over it. That's why you see so many grandparents saying, "Amma bandh hogi parvagilla." At a younger age group, it's fine. But when you talk about 13, 14-year-olds, 15-year-olds getting chickenpox, I always see it's very severe. They lose again about a month of their schooling and the immunity drops and everything. So after 10 years, if they have not received the vaccine, I really push for it and I say, please take it. At least one dose. It gives about 85% protection. So that's one. Flu vaccine, like we had earlier discussion. Previously, I was not so much for it. I would say we get so many infections, just flu is one of it. Why make a big deal of it? But then my perception has also changed as I started practicing post-COVID. I have seen so many kids who have got collateral immunity. People who have got flu vaccines, I have seen them falling less, falling sick less often. So I have started promoting flu vaccines generally with my entire crowd. So yeah, these are 3 things. And I would like to get ma'am's feedback on these 3 vaccines, typhoid, chickenpox as well as...
I have one question, which is in NIP they do not recommend MMR?
No.
It's MR.
Yeah.
Is MR vaccine available? I don't even know.
It's
a plain MR.
For us, no.
Right?
But MR is available in the government sector is what I've heard.
Yeah, because for us, MMR is a must. From the time I've been practicing, MMR has been the vaccine. A little bit about MMR. I think you did mention after 5 years, you know, not to give MMR or MMR, but I think it is okay to give MMR at an earlier age again. And I say this because the government is also doing these rampant campaigns to eradicate, because there's been a resurgence of measles again in a lot of areas. So MMR can be redone again beyond 5 years. I also say this because if the kids are going abroad and you guys are also filling up the forms, you would see that the government of the US wants a tighter level of a vaccine. And if it is not there, they recommend the child, even at the age of 18 years, to take an MMR. So we could safely say an MMR is safe to take at a later age as well.
Absolutely agree with you on that. I have ended up giving so many of my patients.
And rotavirus beyond 6 months, not only because the diarrhea is not there, but rotavirus vaccine itself can cause intussusception. So then the benefit of the vaccine gets outweighed by the disease, a very, very severe emergency. So that's why rotavirus. Typhoid, I really would recommend, it is my what do you call it? I would call upon all the practitioners to give typhoid vaccine, family physicians, because we as pediatricians give typhoid vaccine very early in life. Now it started at 9 months. Earlier it used to be 1 to 2 years. The reason for that is most kids are out in crushes and daycares, and they want to prevent the infection in young children. It also decreases the burden on the community. So once you immunize your patients against typhoid vaccine, the typhoid burden itself will come down. I know your practice will also come down treating typhoid, but it really makes a lot of difference. And then it's not that you've had typhoid once in life and it's forever. You've had, you know, repeated endemic typhoid. So it's just a very, very big social and economic burden on the country if we keep getting typhoids. So please do recommend typhoid vaccines to adults.
6 months is from well known, we can give typhoid vaccine.
But I do it at 9 months because it still gives a lot of pain. And,
and we have the flu vaccines as well coming.
Right. And the flu vaccines, it's wonderful to do flu vaccines annually, but I do understand patients or parents come and say every year the vaccine, what do you think? So in that case, 6 months to 5 years is a good idea because children do not have enough immunity and they get sick very often, especially early years, under 5. They get a lot of cross infections from schools and daycare, so it's wise to give flu vaccine. After that, if there is no comorbidity and the child is a healthy child, when I say comorbidity, it means doesn't have asthma, doesn't have any other chronic diseases, renal issues, or ear infections. Yeah, type 1 diabetes. So if they do not have comorbidities, then it's all right. We can probably take it easy. But then adolescents, when they're going into colleges, again would be a good idea because again it's absence from school, absence from work. So I think it's wiser to take flu vaccine annually in that case.
But what would be the best time to give the flu vaccine? I mean, we get the northern hemisphere and the southern hemisphere.
So I normally say you cannot aggregate all your patients in April and in September. Yes. So when you give the vaccine either any point of time, just do the cycle. Just do, if you've done it in May, use April, May the next year. It doesn't matter. You're giving them enough. And then every year the strain is updated. The vaccine companies are very, very proactive upon changing the strain every year. So it doesn't matter what time of the year you do it. But they recommend whenever your child falls into the 6 months or whenever your child comes to you, that's the best time to do the flu vaccine. Does the NIP have hepatitis A? No, right? Yeah. So that's another one. I mean, I recommend all vaccines to my patients. Not that because I think vaccines are our insurance policies. This is one insurance policy that you're taking to prevent yourself from suffering and from spending money later in life. So please educate, please encourage. Dr. Leena was saying about cervical cancer vaccine. Patients say get sterility. I just straight away tell my patients, you will prevent cancer. I don't say anything else, human papilloma virus, as a cancer prevention vaccine. Even if your vaccine is 50% efficacious, you should be very thankful. Which cancer has a vaccine? No cancer has a vaccine. If you could get a vaccine for breast cancer, I mean, I think we would probably go into another domain altogether and then, improve the quality and longevity of our populations. So those are my 2 bits that come when I counsel my patients to take vaccines. I tell them to take all vaccines. I said it's up to you how much you want to spend, but if you want to ask me, I would say take whatever you can.
Another thing would be the wholesale and the acellular, the big question, the painful or the painless.
So DTAP is diphtheria, tetanus, acellular pertussis, and WP is wholesale pertussis. Up until a couple of years ago, India went very aggressive upon the wholesale pertussis vaccine, saying that the efficacy and the immunogenicity of a wholesale vaccine is higher than the acellular pertussis vaccine, which is true. It does have an advantage on immunogenicity and antibody production, but the adverse effects of the wholesale pertussis vaccine are quite severe, and that's the reason acellular has come into play. When we come towards efficacy in diphtheria, so we basically talk about pertussis. Acellular pertussis give 87% of efficacy after 3 doses. But pertussis, wholesale pertussis, gives 90%. So there is a difference of 4%. It's not like it's a radical difference. So again, the price point, if your patient can afford acellular, it's okay to do acellular. After the age of, what shall I call it, 18 months, 4 doses of whole cell, if you have done, the 5th one should be given an acellular, because again, there are really intense reactions to whole cell pertussis after the 4th dose, because the antibody reactions are more. It's like a boosting effect. So after the first primary 18-month booster, the first booster vaccine, the next one should be acellular. If somebody asks me, I am more in favor of acellular pertussis, not for any other reason, because the children get so many vaccines and we don't understand. Dr. Beliappa took shingles vaccine and has a body ache and everything is hurting with one vaccine. When we do these multiple vaccines, we literally do maybe 7 or 8 strains in one sitting. It is okay to give a comfort of a painless vaccine, a less painful limb, a high fever. I don't think we should get our children into that kind of situation just for the 4 to 5% efficacy. And we have to remember that acellular pertussis goes on for a very long time, from 18 months, then we give it again between 4 to 5 years, then we give again at 10 years. So, and now adult vaccine, the Boostrix also has TDAP, a minor strain of pertussis. So we are actually getting ourselves boosted by the acellular pertussis to keep it out of the community. So I think it's okay. That is my personal practice. But then again, it is totally up to the practitioners and also the pocket of your patients.
Yeah, as pediatricians, many times we become insensitive to the child's thing. Like you said, we give about 6 to 7 strains. Definitely they deserve a painless one, at least.
Less painful.
Yes, sir.
The time to give, or the month to give influenza vaccine, we were discussing this morning. The year by year the patient comes around that time, we tell them to take, maybe in month of September, October. This is how I was under the impression that you should give. I realized that you should give it pre-monsoon, because there is a spurt of influenza around that time. So I was told by RK this morning that it must be given pre-monsoon first dose, because the spike happens just about that time. So not when the patient is due to give, but shift all of them to pre-monsoon.
Can I add something there? So, like when I was reading about the flu vaccine for today's thing, they also mentioned that North India should be given pre-winter definitely, and the rest of the country pre-monsoon. So if you can even roughly differentiate that, but broadly speaking, pre-monsoon. So April, May is when you should recommend to the parents, so that by July, September, they will have finished.
So I have a question, and what I'm saying is that if you are giving annual flu to your patient, your expectation from the vaccine is that the antibody or the immunogenicity of the vaccine will stay for 12 months. So when we give to probably a new patient, it's okay to give it pre-monsoon or pre-winter. But what you're actually doing is you're giving them a cover for the whole year. So in my opinion, I think you are just covering through the year.
So we were having this conversation this morning.
I'll just present some data. So I'm an infectious disease physician, but I also am associated with a molecular biology lab. So in the last year, we had 600 samples tested for influenza. And there was a very interesting pattern seen last year, which is not the typical pattern seen most years. So very true. India actually has 3 different epidemiologies of influenza. There's a scholar who's a pulmonologist at Sher-e-Kashmir University. He's recently written a wonderful review. So if you look at the pattern in Kashmir, it mirrors the pattern we see in North America. It's a winter peak which starts in September, October, lasts till February, March. Most of our guidelines come from North America or Europe, right? What we see in southern India and also eastern India is the monsoon peak. So the typical peak we see is in July, August, and then the early part of September. In terms of immunogenicity, the antibody we want, the antibody response to be quite robust, just like we did the COVID vaccine. So 2 months before the onset of a peak is the best time to actually give some kind of an annual vaccine. Last year, the data from last year was, we saw a monsoon peak, July and September, July and August. Most of the cases were influenza A, H1N1, pandemic 09 strain. 20% was influenza B. Fortunately, both the trivalent and the quadrivalent vaccine covers. Influenza B, we mostly see Brisbane strain. This year, we had a second peak in February and March. This peak was largely driven by epidemiological phenomena in North India. So what we saw was influenza A, H3N2. What do we take from all this? I think definitely, as you suggested, April, May, June, or May, June, July. I think these are the best times to initiate conversations with most patients in India, in Bangalore, about influenza and vaccinate them, so that they are prepared for this thing. But I completely agree. This is an annual vaccination cycle, and people do very well, and physicians do very well when we have a habit cycle, like when I practiced in the US. We would start, the whole system would start by saying September is here, new vaccine is available. Of course, the vaccine manufacturers don't necessarily take Indian strains, circulating Indian strains and manufacture them. So we basically use whatever the global, economic centers determine. So just wanted to share these thoughts.
I have a question for you. So what I'm understanding is every year all these flu strains are floating around, and these strains are presented to the WHO and the CDC and all, and they determine what should go into the flu vaccine, right?
Yeah.
I think it's presented in February or March, if I'm understanding it correctly.
So there are two cycles. So in the northern hemisphere, they all the strains that circulate, in say North America or Europe, these are used for making the vaccine for Australia. In winter, in the northern hemisphere, which is summer in Australia, so in the Australian summer, you take samples from the southern hemisphere and use that to predict what will circulate in the northern hemisphere. So the WHO, through its influenza surveillance network, actually samples from across the globe, but primarily in Australia and South Africa, and some in South America, and then that's kind of how the annual vaccine is.
So my question is, if it is presented around some February, March, then it takes some time for them to make the vaccine.
Yes.
So should we go, and so assuming that it will take at least a couple of months to make the new vaccine, should we take the one that's made available by autumn, or it makes no sense to vaccinate pre-policy?
Yeah, no, that's a great. I think in India we don't have that luxury. We have to basically use whatever is available. Whatever is available.
When the new batch comes. Primarily, that vaccine covers four.
But that's a good point. See, what happens is influenza B. If you look at the quadrivalent vaccine, there are two strains of influenza B which are covered. I think we're running out of time.
Yeah, we have the panel discussion on flu vaccination. We can
Okay.
take any other questions, national and universal? Yeah.
So what about the painless vaccine? They had one cat recently in the Rainbow. So you were talking about the pain for the kids. So what's the take on the painless vaccines? Are they good? Should we?
Yes.
Is that a future?
Definitely, they have great efficacy. Painless vaccines have great efficacy.
We can start doing that.
We have been doing that. In fact, in the West, wholesale has been taken away. There's no company who manufactures wholesale. It's only in India and Southeast Asia, some countries have a wholesale producers vaccine. Otherwise, they've been taken away from the West. So,
thank you, Dr. Gurmeet, and thank you, Dr. Aarti. I would like to invite Dr. Rakya Prasad to come onto the stage and to present the token of appreciation. Dr. Aarti. I request Dr. Aarti to stay back and make an announcement for the AFPI Karnataka State Conference.
Yes, yes. So, really my pleasure. AFPI Karnataka, Dr. Mohan spoke about the
You can leave it up.
So, Dr. Mohan spoke about the growth of AFPI in general and AFPI Karnataka. One of the things that AFPI Karnataka in the last year has done is it has expanded its presence to other cities in Karnataka. So we conducted, led by Dr. Ravi Kulkarni, he stepped out for coffee maybe. We conducted the last state conference in Mysore. The next state conference is being conducted in Belgaum at KLE, that is JNMC Medical College, by our Belgaum unit of AFPI Karnataka, and they're doing a fantastic job. I welcome all of you. Please come participate in the conference. I welcome any of the residents, postgraduates to submit abstracts. There is still an open window, and please come be part of this. It'll be wonderful. We have brochures. Each of you should have received a brochure in your delegate kit. Please take a look at the topics. These topics have been curated keeping local priorities in mind, but they're also being curated keeping topics that family physicians don't often get to participate in or listen to. So I welcome you all. Thank you.
Thursday afternoon.
They book an online slot, is it? Or
Not really, you can
just walk in and
because it is fixed for that Thursday afternoon.
And they have multi-dose
So tick-borne encephalitis also is considered as one of the travel vaccines. Not available in India though. So outside of India, when they travel to Eastern Asian or Northwest European countries, and there is a 3-dose primary immunization schedule or 2-dose primary immunization schedule, which is given 0 and 4 weeks gap, 4 to 12 weeks, and a booster after 9 to 12 months after the second dose. And other vaccinations required when traveling to India. These are the new things which I found, that OPV vaccine from January 2014. So all travelers visiting from these countries, Afghanistan, Ethiopia, Israel, Kenya, Nigeria, Pakistan, and so on, to receive OPV at least 6 weeks prior to the departure. One thing which was not clear to me when I did research or when I studied multiple articles, so whether they want the patient to complete all the dosages prior to coming to the country, or whether just they want to they want the patient to take only one dose. It was not very clear. I felt that the whole primary immunization should have been completed with maybe a booster 1 year, 2 to 4 weeks prior to the travel, and should have taken the booster. Is what I have understood after reading all those things.
So actually, if I can add on,
yes.
There are many students who come to us within 1 month of traveling. So they are today is July 1st, they say I'm traveling on July 30th. So at that time, we have to do whatever best is possible. They take their subsequent doses in their country.
So yellow fever vaccine should be 6 days prior to arrival, 6 to 10 days basically. So in few articles it is 6 days, few days, 9 days, 10 days. So 10 days, but the yellow card which you take now, it is valid only after the 10th day of the issuance. So other recommended vaccines are hepatitis C, B, rabies. All these are recommended vaccines, they are not mandatory vaccines. So as pilgrims, meningococcal is mandatory for them, and hepatitis C, B, influenza, pneumococcal are recommended. The pneumococcal is recommended, especially when the age is more than 65. Most vaccines can be combined and given on the same day. Even the live vaccines, inactivated vaccines can be combined and given the same day, depending on the patient, on tolerance of the patient. So frequent dosing vaccinations, usually 5 days grace period is allowed, except for the rabies vaccine. And observe all vaccinated individuals, 15 minutes, 30 minutes. 2 or more live vaccines can be given simultaneously at different sites. For 4 weeks gap, the site is same. The site is not available for giving multiple vaccinations, say 4 or 5 in one day. So if the site is same for 2 live vaccines again, so better give it 4 weeks apart.
What's the minimum gap you give between 2 inactivated vaccines?
6 days. No gap. I mean, if you're giving the same vaccine.
Not the same vaccine. For example, I want to give typhoid and then Tdap. I can give it together, but if the patient is not willing for 2 vaccines at the same time,
2 weeks gap.
2 weeks is good.
2 weeks is good.
Even 2 days.
Yeah, 2 days. Yeah. If you can give on the same day, you can give the next day also.
If they want to take one at a time, I can ask them to come back the very next day for
24 to 48 hours also if they want to recover from the thing.
Okay.
So always see the documentation before giving any vaccine certificate for travelers. So patient is unsure of vaccination, lack of previous vaccination covered, unsure of completion of dosage. Do not hesitate to check titers of antibodies. Do not hesitate to repeat the dosage to the patient. If you think doing titers is a costly affair, or repeat the dosage at least. Okay. So the pre-employment vaccination, there are no specific guidelines for pre-employment vaccination in India. Depends on the nature of work. Only you can recommend the vaccine to the persons who are coming for a pre-employment fitness or for a pre-employment vaccination, like for food handlers, workers in the F&B industry. So typhoid vaccine and hepatitis C vaccine can be given. Vaccines like influenza, pneumococcal are recommended in work of occupational hazards for respiratory illness. And healthcare workers, again hepatitis B, Tdap, COVID, influenza, pneumococcal. List is endless. You can recommend all vaccines. So there is one study which they have done in around more than 200 corporate institutions from 2019 regarding the workplace wellness program. It showed that no one has really taken any measures to tackle an outbreak of any infectious disease at the workplace. So lack of employee awareness is one of the crucial factors that affects the success of any wellness program. So, even the annual vaccinations like influenza vaccines also, the workers or the employees, they doesn't have any idea. So this is a good article if you want to study, you can go through it. Multiple studies also associated with this article. This is a yellow book for vaccination or for the travel guidelines. Depending on country to country, it's available on all e-commerce websites. Cost is almost around 5,000 rupees. Depends on country to country how the guidelines change.
So COVID is compulsory for all the employment, pre-employment, Corona now? No, it's compulsory, 2 doses.
None. There are no guidelines. Depending on the company to company, if they want their employee to take the vaccination, yes. But there are no definitive guidelines. They are not keeping it mandatory.
Yeah, there is no government mandate.
There is no government mandate. In fact, in India there are no pre-employment vaccination guidelines.
Yes, that's right.
So this is the documentation for yellow fever. this vaccine, this yellow card is required. This is also called as an international certificate of vaccination or prophylaxis. So you can include other vaccinations also in this. So they are valid after 10 days of vaccination, and other vaccinations which are called OPV or IPV or meningococcal vaccines. So this is our card with the name, the vaccination date, and if they don't want to take the vaccination, there should be a clear contraindication, and it also should be filled. Second image in the slide. Open for questions. So thank you, and these are the different vaccinations, different brands available with their prices.
So how about the second case? The second means the girl who had not taken the vaccine.
So the first one you were asking anyway. So for her only some 3 or 4 vaccinations were there, especially varicella, MMR, and meningococcal. So we gave all the 3, and it was almost 2 or 3 months for travel. We gave all the 3, but MMR they wanted to check the titers first. So MMR, measles and rubella titers were good, but mumps titers were not good. So we repeated the vaccination.
One point which I wanted to make here is typically every university has their own set of formats, and there would be a column which has required vaccination, which is a must give, and usually MMR comes in that category. Then there would be certain recommended vaccines and the optional ones. So the recommended would be, usually it matches with your national immunization schedule. And another thing is, in CDC there is a destination tool which is available. If you just go there and click on the country, they tell you whichever country you're visiting, what are the requirements. So that's easy because you possibly can't remember so much. And any thoughts about dengue vaccination, because that is the latest one coming up. By research I found out is this dengue vaxia, which is available in US. And the interesting part is that dengue vaccination they're recommending in people who have, or children from 9 to 16 years, particularly who have had an episode of dengue. And the reason being that if you have a second episode, it is worse and it is more serious. And beyond 16 years or less than 9 years is not recommended. But in India, I'm not sure it is not yet here. So just I wanted to make a point.
Hi, Dr. Vaitesh. Very nicely put slides regarding the vaccinations for the travelers. I just have one question. This condition we cannot vaccinate once they've crossed 5 years, that is tuberculosis. So I recently had one 21-year-old boy who wanted to travel to Texas University to pursue his higher studies. He was through with all these vaccinations and he had the records. But then it was mentioned that since he is coming from India where TB is endemic, so he had to undergo TB gold interferon test. To our surprise, it came intermediate. So what do we do now? Any suggestions? Any thoughts for that? Intermediate. Not mantle. Gold interferon.
They have to do an X-ray chest.
X-ray chest or mantle.
Do we treat with INH prophylaxis? Is it a mandatory?
That's the question. I think if he has to go, he would have to.
Actually, I'll tell you what happens on the other end. Let's say this is a student, not a clinician, a healthcare professional. It's a little different. So intermediate, you can actually, sure, if it is intermediate, if you're unable to resolve that, you can either retest because the university may need that, or you can do the skin test if you have time, because it takes 72 hours. If all that is not possible, you can write a letter. You just write a letter. I am Dr. So-and-so. I have examined this patient. This is a 22-year-old so-and-so. It does not have any symptoms. This test was done because keeping in mind the requirements of the university form, there was no pre-test probability or concern, suspicion of tuberculosis. The symptom assessment was negative. I certify that he does not have any evidence of active tuberculosis and is not contagious. He may travel without restriction, and he may pursue, in my clinical opinion, pursue the course or whatever in the US. If any questions, please contact me. This is my phone number, license. This is the letter you can write. Many times with a letter which is clearly written like this, which has these details, there is usually no issue with airports. Once they get into the university, what may happen is, see, most universities don't really care. This is just an administrative practice. Now, if this person is a clinician, most universities or hospitals don't even trust what testing we do. That's a fact. So they are going to repeat it anyway. And I'll tell you what happens to, say, a doctor. Say your TB quantiferon test in the US comes positive. You'll be offered, somebody will offer you take INH or rifampicin and INH, whatever. You can go meet the ID physician who will do exactly all these things. And then the diagnosis made, if there is no evidence of active TB, is latent tuberculosis. Latent tuberculosis, you offer treatment, but at the same time, latent tuberculosis is not contagious. Nobody else is going to get it. So this can be documented by the ID physician. If the hospital has a very strong policy that if you are an immigrant physician with this, you must be treated, then the doctor goes and treats, or a nurse receives this treatment. Otherwise, it's on clinical grounds, this person is not going to actually transplant. So those are the nuances of it.
Yeah, but their applications very clearly mention if it is positive, you have to do an X-ray chest. The other issue happens is I think they have to upload it. So I don't know if our letters. No, I'm just saying, if our letters make. But I think the best thing to do is tell them that I don't know, go there and repeat it.
No, you can email such a letter.
Yeah,
we've done it. Yeah.
And now they are not. Some of the universities are not even accepting our testing. They say you come there and do it. Yeah. So.
There's a choice, either TB Gold test or chest X-ray, one of the two. And if TB Gold test is positive, that doesn't mean that's not a disqualification for going to USA. There they give INH prophylaxis. That is the practice they are doing. And full 6 months course they are giving.
No, they say MAN2 or TB, not X-ray.
Okay.
MAN2 test,
X-ray also is
MAN2 test or interferon test.
Right.
And MAN2 I don't do because invariably it can come positive.
Right.
Because people living here are sensitized, which doesn't mean, again, it's the same thing, right?
TB Gold test is even more specific, sensitive than MAN2 because...
No, MAN2, I think a lot of false positive.
Yes. See, technique and also the PPD used may not be ideal. So to get the accurate result, TB Gold test only for these foreign travelers, otherwise no need at all.
No, all these universities, most American universities
Right.
are asking. But the worst is UK, Canada, Australia, they just want you to do X-rays. Like go and get X-rays done. And worse than that is, if you've done it 1 year before and you delayed it, you have to repeat it.
See,
I mean,
and also
so
it
silly.
detects only pulmonary, not extra pulmonary. Whereas MAN2 and the TB Gold test detects subclinical TB anywhere in the body.
But it's sad because then there's so much of exposure, right? Unnecessary.
There is no logic in their requirement. They are just following like what Indian people are following some formalities, just like that.
Every Indian has tuberculosis.
Yeah, they are also like Indians. They are following this without logic.
Dr. Sachin, pulmonologist.
Just to add on, Dr. Sachin, pulmonologist, practicing at Sakra. So we commonly see this thing, what you asked. So actually see, quantiferon golden tube is a test which we do not do for routine clinical practice, because Indian setting, if you randomly do, 50% of our population is positive. So it means that you have a latent TB. So Indian setting we do not treat except somebody is going for transplantation and all those settings. Now coming to the children or students going there. So generally they will certify that if it is positive, then you rule out active pulmonary TB, because that is what matters to them. They are not bothered about the person but to spread of the disease. So they require the consulting physician or the pulmonologist, whoever is there consulting, that they do some workup, including physical examination, ultrasound or X-ray at least, to rule out active pulmonary TB. And you certify that it's a latent TB, then it's okay, nothing to be done. Sometimes the job requirement, suppose somebody is going to immigrate there, they are working there, then generally that scenario, sometimes they make it mandatory to get treated there. And they give a choice, but they say that better to get treated because we are going to stay here. And they generally, as somebody highlighted also, they offer only one drug which is not good for our Indian setting. Because pre-test, if you see 20% of our population are already resistant to INH only. And only INH is never recommended in our setting, because if this person ends up having a real TB, then these drugs will not act. So generally in that scenario, we generally prefer at least 2 drugs, if not 4 drugs. So sometimes we treat, if it is mandatory requirement from the pre-employment perspective, then we treat as 4 drug ATD, because 10% chance is that this person is going to have an active TB in his lifetime. But in Indian setting, positive quantiferon or negative quantiferon is not used to rule in or rule out disease. But if you are de novo born at US or UK and you have a positive, then you are treated as TB. So in Indian setting, generally it doesn't require much of this.
Now, NTEP guidelines is revised. The context of the active TB is given INH prophylaxis. Again, I question about what logic you said is same thing applies here also.
Yes.
There is no logic in this.
So this has been started last, I think, couple of years, and they, even if you write a TB medicine, they will contact the ID is created and they will contact the creators and they are giving contacts. But there is again a task force reviewing the situation.
So, do you agree? Is there any logic in that, giving INH prophylaxis, single drug? If they are on the process of getting active TB, we are creating an MDR TB.
Yes. That is there actually. So
I don't know recent NTEP guidelines.
Yes.
And when I argued, discussed in a big forum, they said they have made a study, a multicentric study, and found it is beneficial. In the same people, same team had disputed and discarded this logic quite many times. Now they have agreed and they have implemented NTEP guidelines. All contacts will be given INH prophylaxis for 6 months.
Yeah, and this is going on some pilot project at level. It's not like throughout the India, but in Bangalore they are doing that.
Yes.
Let's see, but it is not logical and not recommended from the clinical point of view.
Very good. All contacts. Earlier it was
not required again leave it, because 4 to 6 weeks it will subside. And only thing you need to see that secondary infection, because I ended up having bacterial superimposed infection.
But I think that, again the guidelines is give INH.
Again, for an immune contest it will be counterproductive. Thank you.
One point I would like to add here is about the NOC vaccine. So Stemerile is available in the market, and if you want to give yellow fever vaccination for your patients, you can still give. But only few countries recommends to get it from a WHO recognized centers. So you can give, and you can give these yellow cards. I just got few yellow cards. If anyone wants to take and see how it looks like, you can give it in your clinics as well. So let us move to the next topic, and thank you, Dr. Venkatesh. I would like to invite Dr. Ravi to come on to the dais and present token of appreciation for our speakers and chairperson. Thank you, speakers and chairpersons, for the wonderful session. Thank you, everyone. Thank you, Dr. Ravi. So let's move on to the next session, last session for the day. It's a panel discussion. So panel discussion regarding vaccines for the chronic diseases. So let me introduce the moderator for the session, Dr. Siddharth Kohli, who is working as senior consultant, pulmonology and critical care medicine specialist at Sakra World Hospital. He is a super specialist in pulmonary and critical care medicine with more than 17 years of rich and varied expertise in all areas of chest and respiratory disorders. I welcome you, Dr. Sachin.
wonderful audience, and we had a very great participation. I think it's no requirement of me here, and all of you are so actively participating. Anyway, I will take the lead and start with the questions on flu and pneumococcal vaccination, which I think especially is important in elderly population to prevent mortality and morbidity. Starting with Dr. Uma, flu has been discussed now. So what do you think in your practice is flu, and how important or how serious is this disease?
Hi. So, I didn't get you.
What is flu?
Okay.
And how serious is this disease in your practice, in the population which you see?
It is a highly infectious disease and most communicable disease, and which is affecting the respiratory tract, as we all know, like upper respiratory and also it can affect lower respiratory tract, and it comes as an epidemic, like it comes as a seasonal flu, and annually, before the flu season starts, it's very important to prevent flu epidemic. So it's important, and it affects all ages. It's not that one age group gets affected. It affects all the age group, especially the school going and office going, and also who works in crowded places. So, and when it starts, in the season, it comes like peak. So before that, we should be ready, for treatment, and also as a physician, it will be overwhelming during the peak seasons to see all the age groups affecting, and also elderly and young kids, they get complicated with pneumonia and other complications. So yeah, as it is affecting all age groups, and especially the younger and elderly population is getting severe disease, it's very important to be prepared, with the vaccination annually before the flu season starts.
Okay. So, what do you say about this? How serious is the disease? Because the Indian population, they think flu is just a viral, and why do you need a vaccine when there is not, if it comes and goes, your immunity increases? So how do you convince your patients?
Yeah, so first thing is, like Dr. Uma said, it affects all age groups, so pediatric as well as adults, and adults especially with comorbids, so diabetes, hypertension, heart disease, liver disease, kidney disease. So this is what we have to educate our patients about, that patients with comorbidities can develop complications because of a flu, that is an influenza viral infection. The common complications that we come across in kids, that is a pediatric age group, we have seen otitis media as a very common complication, and in the adults we see secondary bacterial infection with pneumococcal, we see meningitis, and of course severe acute respiratory syndrome, and finally death. So complications is what is prevented by vaccination. The same doubt that we had encountered during COVID vaccination season. I have taken both the vaccines and yet gotten COVID. So it prevents mortality and morbidity and hospitalization rate.
So how do you calculate, how do you see that there is a super infection?
Add on these things, because in my clinical practice, 2 things more I highlight. One is that loss of school days. Because all the kids, they start to go to school and they will invariably lose their days, even the work for that matter for adults. Second thing in my clinical practice like asthma, COPD and other diseases. This is one of the common precipitating factor for severe exacerbation requiring admission. So once they are admitted also, I highlight that this, because you would have taken, maybe you would have avoided this particular thing from coming to hospital and hospitalization requiring ICU care also sometimes. So this is also one thing, and in general asthma and COPD, like arterial respiratory disease, so I might highlight that flus, influenza are 60% cause like the poorly controlled asthma, COPD and exacerbations. So requiring antibiotic courses and all those, they invariably will take antibiotics without any benefit. So these things also should be taken care of.
So coming back to you, so now we know the complications. What percentage of the unvaccinated who come to you, you feel, other than the having comorbids, anyway you would educate them, what about the importance of giving this vaccination to everybody who is not even having comorbidity condition. So what is your take on that? How do you, what is the importance of giving that, giving the vaccine to?
As we all know that if they are not vaccinated, they are prone to get the complications. We need to educate them and missing school days or office days, and getting into hospitalization or more investigations, because the symptoms, if they don't vaccinate and if they get the flu, they as they keep moving around with the symptoms.
How much is the severity in non-COVID? If you don't go to hospitalization, what would be the work loss or the school day loss in the population? Normal.
On average, 3 to 5 days they have to miss, because their symptoms will take up to 5 days to 1 week. At least first 3 to 5 days they have to miss their school days or office days. So they need to, even that can be prevented if they get vaccinated.
I think you want to add on to that, to know the morbidity
Yeah,
and
also
normal.
because the virus has this property of changing its form because of mutations, the antigenic drift and antigenic shift. So the severity may increase year on year, and this is a highly contagious virus. So even if one child or one person in the family has caught it, it can spread. And if it is severe, it can lead to a epidemic, pandemic. That is where the role of the vaccine comes into play.
And one thing more, generally we see this is a cyclical phenomena. One person getting is spreading to others. So we also educate that even if it's mild for the kid or maybe the healthy adult, the same thing could be disastrous for the older elderly living at your home. So this is also some point to take. And second thing, clinical scenario, generally healthy adult without any comorbidity, pre-comorbidity, we might skip for flu. That is my personal opinion, like except for some profession like public dealing or exposed to some, as of the influenza vaccine. But with comorbidity, we should always reinforce all any allergies, asthma in the background, diabetes for that matter. Those things, they should take every vaccine.
That's like we did for the COVID, like you give a blanket therapy so that the more susceptible comorbid patients can be prevented.
I think
I think post-COVID era, though COVID has become an endemic, we have seen a lot of people with reactive airway disease, especially in Bengaluru, where the air quality index is very low. I think which is causing a lot of flu outbreaks, and with the drastic climatic changes and the seasonal trend involved, I think many of them have flare-ups of all these. I think in that context, if we individualize a particular case, I would recommend a flu vaccine. Otherwise, for a healthy adult who is doing his regular exercise, including the breathing techniques, and who is healthy, I would not want to recommend a flu vaccine as a routine schedule, even in adult immunization.
So, do you agree with that?
Yeah, I want to add on, like in my practice, most of this Whitefield and IT population, they're already having some or the other allergic rhinitis conditions. So for them, I would strongly, if they come to me within 2 months with the 2-3 episodes, then I would strongly recommend them to go for an annual, that in the month of April and March, before the flu season starts.
So we have seen some pandemics with this flu. So can you tell, can you have any, give us some, put us some light on when can we expect the next pandemic with this flu virus? What are the changes in the virus that can, because now we had a COVID, I don't expect any thing soon. I think the WHO and all actively promoting this. So how do you think, what is your take on that?
Usually the pandemic happens with the antigenic shift.
Yeah.
So
How was the process of that? And
so antigenic shift happens when the two strains of virus, when it affects a single host at the same time. For infection with those two strains, there will be genetic changes in the new strain. Reassortment happens at the genetic gene level. So that leads to the
so that is avian flu.
Yeah, avian flu with the human. The pigs are most susceptible for getting both avian flu and human flu. That's when there will be reassortation at the both avian flu and human flu. It gets an infection at the same time. There will be genetic reassortment at the pig, and it gives a new strain. And if this happen, antigenic shift happen in a greater population, that is when we can expect a sporadic cases like outbreaks.
So there is antigenic drift and antigenic shift.
Antigenic drift.
Can you explain a bit more about it?
Yeah. So antigenic drift is basically accumulation of mutations. That is the reason this virus changes form every year and a new vaccine needs to be developed. And shift is, there is adaptation that occurs which will again cause the virus to change form. And the severity may differ, the presenting symptoms may differ. That is the reason that the companies are constantly studying these properties, and they have kind of templatized this whole vaccine production. And when a shift or a drift occurs, that particular subunit is processed and then amplified and then made into a vaccine. I'm just trying
Which
to...
is more dangerous, the drift or the shift?
So I think drift is more for the vaccine, yearly vaccine alteration, and shift is more clinically relevant.
That is when the
epidemiological aspect. So maybe see, to answer your basic question, generally, historically, every 100 years, generally we have a very big influenza outbreak like this, be it coronavirus or influenza. And generally it doesn't happen so soon because the viruses want to, how they want to spread. If they make high mortality, it's a dead end for the virus itself. So by survival, this thing, they will be a milder infection so that they can propagate. So this is by their nature, except few cases where like COVID and all those things, but generally they will try to not kill the host so that they can spread, because it's a dead end for them also. So eventually, even if you have like H1N1 also initially came, the mortality in media was also very high, but down the line it mellowed down, because for the virus to survive, they need to just keep the host alive. So that is something they will learn and to survive. So I don't think like this major.
I think whether there is a shift along with the non-human host, and when it shifts to a human, then it becomes difficult, and the vaccine has to be done from the beginning, from taking the antigen of that disease. But now in the drift cases we already have, and then they keep rotating the vaccines. So that's when. So what is the logic in giving it yearly? So do they change drift happens yearly?
Most of them maybe yes. Some minor changes are yearly. That is why if you see, but there is a catch in that. Most of the research is that what you see the drift are Western, like the strains and all those things. Although they claim Eastern Hemisphere, Western Hemisphere, but Indians data is lacking in these all vaccine. This also should be taken into mind. What we might have, the drift might not be same as US or UK or Europe for that matter. But vaccine companies maybe are not tailor-made to our country. So generally speaking, in our practice, October time, if you see, they launch a new every year mid-October. So September or October time, they launch a new. So generally we encourage them to take around that time when the new vaccine is there, for whatever benefit that the new strain they have been keep into consideration. And by winters they are protected.
So like every year they change, there is a drift. So we need to have a new vaccine for that. Based on the previous year's drift, we create a vaccine and give it to them. Okay. So and any serious flu where we can who should and must take this flu vaccine?
Yes, so elderly and definitely the ones with comorbidities, diabetes, COPD, asthma, heart disease, and immunocompromised adults.
So this the protection lasts only for a year for that thing, or why do you give it yearly? Does the immunity drop down after 1 year? Or that?
No, since their immunity is already low and the virus has changed form.
For general population, it is yearly, right?
Yes.
So what is the why yearly? Why not 2 yearly or 3 yearly or 5 yearly?
See, the mutation, whatever happens, point mutations in the drift, the mutations also will be ongoing, and these mutations especially evades the annually acquired immunity from the previous strains. That's why we need to give, and the WHO also will collect the data from the system, where they collect samples from across the world and they study the strains, and from that data WHO updates the strain, which strain should contain in the upcoming vaccine, so that we are prepared for the next upcoming flu season. That's why we need to, every year we need to change the vaccine. But yeah, definitely it is not completely for an Indian setting, but as there will be movement of people, cross travels will be there from UK, US, so even that gives some extent protection for us also.
So yearly giving over a period of 4 or 5 years accumulates the builds up the immunity.
4 or 5 years?
I mean yearly when you give for a different strain, the vaccine is flu, but the strains are different. So as you give yearly, the person's response to a new drift or this thing, we don't know what drift can happen the next year. So over a period of time, he accumulates this immunity, right? Is that how it works, or?
No, it is every year they build those antibodies.
But that they
can take a dip, and the antibody may not function against the new strain. Hence every year.
Okay. Anything, sir?
Yeah, similar things, because it's not about the like a vaccine immune or like a booster, what you do in other situations. It's not like that scenario. Primary reason why we are giving yearly is because the vaccine might not be effective at all. The new strain, what is anticipated, all is ongoing. So because that could be a common pathway, but after that minor variations, the antibodies might not be the same. So the primary aim is to give vaccine yearly is not because of as a booster effect, but primarily to target a new strains which the vaccine can target.
Okay. So I think that concludes our flu vaccine. Any questions from the audience?
Can you throw some light on treatment modalities?
Yes. Great. In case they get
so influenza viral. So if you club together viral infection including influenza, most of the time it's I think supportive only. Except we do a flu panel many times, so it contains influenza A, B, H1N1 specifically. And if you have these things, then generally oseltamivir, we give 75 milligrams BD for mild to moderate disease. If anybody requiring oxygen or ICU, then the dosage we use is 150 milligram twice a day for 5 to 10 days maximum. But generally, ideally speaking, they should be started within 2 days of symptom onset to be very effective. But for the benefit of doubt, many times we end up giving the patient, even if he comes to ICU, we continue for 10 days, 150 milligrams BD for oseltamivir. But other antivirals, the efficacy also, the data is not too much, so we are not using routinely any other antiviral except oseltamivir at present, clinically.
So one more thing,
So if there is high degree of suspicion, say in case it's a pandemic, no, even if it's an endemic or it's that season, then we should keep that degree of suspicion and start as early as possible. Within 48 hours is the recommendation.
Do you routinely do tests? What are the tests for?
Yeah.
Like, do you routinely do
Now I have patients. So in the same family it is spreading. So every week I am getting the new family close contacts of them. So I am doing the test in only those who have exposure to the positive cases.
What test?
I do throat swab for HIV. Throat swab for HIV. Yeah. And
RT-PCR.
It's RT-PCR test, and the parallelly I'm starting a prophylaxis for the close contact family, which is a OD dose, 75 mg oseltamivir, OD for 10 days I'm giving. Only when we start getting cases only, we will get to know the trend in OPDs. Once lots of cases, we try to see whether COVID and last 2-3 years. But now, as one case came with the report because daughter got continuous fever for 4 or 5 days, they did the H1N1. Then mother got it, so like that we do the test. Otherwise, routinely for all flu cases we are not doing H1N1. And we get to know through our contacts, through our physician groups, then only we do.
Just one thing is, now we have a panel which is available in many labs. They do COVID as well as influenza tests.
But just to add on, generally OPD basis I tend not to do, if you ask me frankly, because it's a cosmetic test, you are not doing any good actually. Yeah, so probably for indoor patient I would advocate at the emergency level, but not for OPD, routine, garden variety, cough cold, mostly support. Even I don't start Tamiflu or oseltamivir for them most of the time clinical practice. So
I actually want to emphasize that point because
actually it is not advisable to use oseltamivir in outpatient practice. I'll give you 3 reasons. The first, clinically it's very difficult to distinguish between influenza oseltamivir only is useful against influenza and other respiratory viruses, with most of it is upper respiratory viral infection. Second, oseltamivir data supports use best within the first 24 hours, latest within 48 hours. Most patients, when they come to you, already have passed that. Third, oseltamivir resistance is a major problem, and indiscriminate use of oseltamivir takes away, as Dr. Sachin mentioned, oseltamivir is the only reliable anti-influenza antiviral that we have. So I actually would recommend strongly against avoiding use, and I agree with testing as well. It doesn't change clinical practice.
So I'll just summarize that we start symptomatic treatment, advise the patient for the red flags or worsening symptoms, and then choose, even for that matter, antibiotics to prevent a secondary bacterial infection.
And then make them
and then oseltamivir as well.
Okay, I think
Dr. Ratna wants to say something.
I want to share my experience. That's all. When there was a COVID outbreak, just before the COVID outbreak, our hospital asked us to take flu shots. So I had taken it, happened very uneventfully. After 4 or 5 months, I developed some itchy rashes over my body, and then I thought it will go away, and I was applying some steroid cream. But after 8 months, it has grown up fully over the body, and I was diagnosed with lichen planus. And then I didn't realize that it was actually vaccine induced because I was fine until then, and slowly one after the other the eruptions came up. And then I was reviewing the articles, and then I got to know that these are the idiosyncratic reactions that can happen in some of the patients. So mostly we only highlight the acute allergic reactions like anaphylaxis, but I know what I went through, and then I had really dilemma whether I should take COVID vaccine or not. Because that time it was only COVID first vaccine rollout that happened, all healthcare professionals were given priority, and then we had to set a role model to the employees, and then I thought, no, I do not want to take a chance, and I want to volunteer and take. But after the COVID vaccine, it was like almost 8 months of flu shot, and which was already primary sensitization of my immune system has happened, and some rashes were already there. But after the COVID shot, the second day was full entire body. I was with the itchy rashes, and then I had to take high doses of steroids to come to a remission. And it almost like 1 year for me to come to that remission. And fortunately, I'm continuing to be in remission. But I just wanted to share my experience because we don't actually know this idiosyncratic reaction, especially in adult vaccination. So not only influenza, but also in hepatitis B, these are the things that can happen. So keep an open eye for the late reactions of vaccines.
Thank you so much. I think that is something the drug companies or the vaccines won't highlight much. And I think there are been, if you can agree, Dr. Sachin, a lot of COVID serious adverse effects have been happening. Which we have been seeing often, which have not been highlighted in the media. Could you throw some light on that?
Yeah, clinical practice, like loosely we term long COVID. So our virus, so vaccine you are asking for something.
COVID vaccine.
Yeah, for COVID vaccine there are two generally.
Any general adverse side effects of the vaccines.
So vaccines, COVID vaccine largely have been okay, but two concerns are there. One is that procoagulant, like pulmonary embolism, DVT, strokes. So they are more in mRNA vaccines in Western literature. But in Indian setting also, some of the patients we have seen without any other comorbidities having coming with pulmonary embolism unexplained. And probably difficult to say whether
heart attacks have also been documented.
So prothrombotic conditions like have been reported more, but it's the Indian setting is difficult because many times the COVID virus itself is also prothrombotic, and there is no real to know that whether they had asymptomatic COVID also, but many times they relate to COVID vaccines. So that is one of the things apart from the routine other allergic reaction, but prothrombotic effects of COVID vaccine. And second thing, I have seen many patients with lymphadenitis after COVID vaccine, especially in the axillary region or the cervical region after 4 to 6 weeks of COVID vaccine. And this is reported in the literature also, and 2 patients we have documented like biopsy proven Kikuchi disease. This is also again related to COVID vaccination. So necrotizing type of lymphadenitis which is persisting 4 to 6 weeks, and we had to give like small dose steroid to counter that. So we have seen these 2 complications in Indian setting more commonly. But data, I don't know.
One point that I would like to make is we also noticed a lot of silent myocarditis, which is leading to cardiac
That's right. Apart from the vaccine, the virus itself, long COVID, reactive airway disease, asthma, many things like reactive airway disease is too common.
But it's very difficult to prove this.
Yes,
that is what these vaccine guys escape from being telling the side adverse effects. Even I have a patient who has had a COVID and is on bedridden almost 2 years now. So we still don't know what is the cause. It's totally.
Every asthma patient I have to ask whether you had COVID, because it's like that. Now, because after COVID many times they never had no family history, nothing. But now they are behaving like wheezing, everything like clinical syndrome, and if you do a spirometry also, there is a reversible airway obstruction. So inhaled corticosteroid they require. But good part is that 3 to 6 months then we can wean them off. So,
seeing the big picture, I think the government usually, if it happens 1 in a million or 1 in 10 million, it is still beneficial for a larger population, and I think we should go ahead with the vaccinations. So coming to pneumococcal disease, we would want your things to tell more about this pneumococcal disease. We would take care of the prevention once you convince our other panelists. So what is the burden of this pneumococcal disease in your clinical practice? How do you see that?
See, there are 2 watershed areas like when we discuss pneumococcal. Before 2017 and after 2017. Why 2017? Because 2017 then all the vaccines company and Indian setting we started to use in clinical practice in adult as well as routine like government guideline for pediatric. Before that it was not in the schedule actually. So if you see the data 2010 to 2016, all the studies will highlight very high degree of like 50 to 60% of indoor admission, 80% of all pneumonias, and mortality also 50 to 60% in all groups like pediatric as well as elderly was because of strep pneumonia. But after 2017, with the usage of like universal guideline, we are giving to pediatric age group also pneumococcal vaccine now, and adults also we are giving. So now it is accounts still the most common cause in adult clinical practice of pneumonia. If you ask me, 30 to 50%. Yeah, of all pneumonia patients will have strep pneumonia. And if you go for invasive pneumococcal disease includes meningitis or myocarditis and all those things. So meningitis, specifically 80% of meningitis is still strep pneumonia. So, and Indian setting, if you see in Southeast Asia, India is the foremost. 98% of your cases from the like Southeast Asian region are from India, pneumococcal. So, because maybe our vaccine coverage is still not that robust, especially in the adult, because what we see in clinical practice, now those who require, they hesitate to take. Actually, it's a very great irony. Suppose like cancer patient, if you see in this lower one, solid cancer, hematological cancer, they are in double digits. So they are 38 times more likely to have. But these patients, even the oncologists, they are not sure because doctors themselves are very not clear. They say that immunity is low, you might have a reaction to vaccine. So the different type of myths are there, and they end up not taking the vaccine. And actually, if you see that the mortality is 70 to 80% in this category, the lower 3, if they get this pneumococcal disease. So that is also to highlight that apart from comorbidity condition, those who have cancer or receiving chemotherapy, they should be proactively immunized beforehand only, so that because they can avoid this type of things from coming. So Indian burden is very high of strep pneumonia, and also with the recurrent type of pneumonia, they end up having a multi-drug resistant type of, because the underlying condition is not going, these are all chronic lifelong diseases. So one time pneumonia begets another pneumonia attack in future. So that type also the problem gets compounded. So yes, so to summarize, it's a major burden, and elderly more than 65, definitely the age group where even if they don't have any of this listed condition, they
prevent the spread of the disease, especially. Fine. So Any questions from the audience?
I just want to add one thing. Commonly asked question. Patient will say, I had pneumonia 2 years back, should I still take the vaccine? So the answer is yes.
How do you convince your patients to take this vaccination when with the comorbid? I mean, he will say only at the end. So the patient comes to us and for the diabetic or the hypertension. So how do we go about in sensitizing the patient about this vaccine and the disease? How do you proceed?
About 65 years, as they are more susceptible individuals, so we have to give 1 dose of pneumococcal vaccine if they are young adults. If they have all the chronic condition, even from the kids, cyanotic heart conditions, chronic liver diseases. So we need to, as a family physician, we need to take that time to explain them the complications. It can affect starting from the pneumonia and also osteomyelitis and septicemia and burden of hospitalization and investigation and the cost also. So we have to sensitize them the importance of as they have that condition, like chronic condition. And above 65, yes, definitely we need to take time and explain them the, especially hospitalization. At that age, if they get into any complications like pneumonia, with other comorbid conditions, by 65 they will have diabetes and chronic kidney disease, all that. So they will definitely go into septicemia and other complications. So as a physician, it's our prime responsibility to sensitize them and make them understand the advantage of taking or the need of taking the vaccine. So that's how we prepare them.
How do we sensitize the patients?
Mainly educate them about the complications, the burden because of hospitalization.
Especially when the vaccine cost is a bit high, which everybody who comes to an OPD may not be prepared.
So sometimes I actually do the math. So for people, when I have the time, so I show them if it's a vaccine cost, how much is it, say 3,000, 3,500, whatever, versus medicine cost, hospitalization, maybe repeated hospitalization, leave from your work, and a burden on another family member. So
yeah,
that's what
To add on, like clinical practice, there are 3 points which should be like the point of discussion of action should come. One is the first visit itself, because only because first whenever a patient comes new to me, OPD sheet I write vaccine schedule. So if they are not convinced at least first time, maybe the second, third time, by the time they will know that maybe this is the standard treatment, like 5 medicine plus 1 vaccine is the way to go. So first visit is the one where I like to highlight the patient is new contact, so that is the time when they are trying to listen to you. Because you are taken for granted 3-4 visit down the line. They become a family friends of yours like that. So they might not take that much seriously. But first visit, you should emphasize these things are a part of your treatment and you should take it. If it takes, nothing like it. But first visit is the second. Second is that if the same patient lands up in my indoor practice, then I say, look, I told you. So because unfortunately our population is like this. So we have to say that I'm not claiming, but it would have helped and might be you would have escaped this. So please come after you recover to take the vaccine. And third thing is that suppose patients are being referred from the other specialty. So we see cross referrals also in OPD also, IB also. And they might be having some respiratory issue or something like that. So then I say that, have you taken the vaccine? So most of the time they will say, no, nobody has told them only. Because the nephrologist or cardiologist, they are busy. They are not, this is not important part of their practice. So they might not think this is important in their context. So that is also very important to pick up from there that other patients, like doctors' patients also should be highlighted that this is something available and you should take. So a minute or two, indoor or outdoor doesn't matter much, and you can put the schedule actually. So I always in my prescription write.
Keep a documentation.
And also you'll see the dosage, but I write both the dosage. Because many times we end up writing only you take today this, but I write after 8 weeks you have to take this also. So that
coming to that, what are the different types of this pneumococcal vaccination?
Making them aware of what is recommended. So if not today, tomorrow they will understand.
So again to you, what are the different types of pneumococcal vaccine? How do they differ, and how do we go about it?
It will look quite complex, but it boils down to only 2 vaccines. Because if Yeah, there is one more. Is there one more slide would be there? I think. Yeah, one more would be there. Okay.
That is more clear.
Yeah, so see that nowadays there are 3-4 vaccines available. So what in India is there is this two. So that is why we have put this PCV 13 and PPSV 23. Other than that, PCV 15 and PCV 20 is also available in Western countries, but in Indian setting we don't have. So we restrict our discussion to these two vaccines. PPSV 23 is a polysaccharide vaccine which is there for 20-30 years. So major companies, only 1 or 2 brands will be remembering, so that is available for long. PCV 13 has come after 2018-19 in the picture. And so
sorry to interrupt.
Yeah.
How do they differ?
Yeah. So see, the main difference in these two are the number of strains, number one. So 23 strains versus 13 strain. So PPSV contains 23 strain efficacy and this contains only 13 strain. But there are major differences in the how the immune response goes about. Because PPSV 23, if you give, then your vaccine protection will wane after some time. Second thing, there are two populations in which PPSV 23 has not been proven to be effective. One is elderly as a group. So more than 65, if you give PPSV 23, they do not mount as much immune response as a healthy individual getting, and this is better in PCV 13. Second thing is that if you have a flu, and that gets complicated by a streptococcal pneumonia, which is very common scenario, secondary bacterial infection. In that category also PPSV 23 is not effective.
Okay.
And so these two categories are black and white. And third is that the strains, they say that these 13 are more invasive, are most common cause of leading to indoor hospitalization or pneumonia or invasive pneumococcal disease. So these three are the major clinical difference in these two, and the efficacy wise also there is a difference in the like dosage schedule. So there are two scenarios. One is person new without any vaccination. Then we prefer giving PCV 13 first, and then after 1 year you give to this PPSV 23. This is more than 65 years of age. But if you are in younger age group and you have a pre-comorbid condition, and like those on the list mentioned, any of the chronic diseases, and few specific things they highlight is if you have CSF leak or cochlear implant, that also they highlight. So these categories should receive again PCV 13, no doubt that comes first, but the duration becomes 8 weeks only. After 8 weeks of this, you give PPSV 23.
After 8 weeks of PCV 13.
PCV 13. And then generally after 5 years, you should give another vaccine of PPSV 23 only, not PCV 13 now. Because it is assumed that this protection of this PCV 13 will last longer, but this will wane 3 to 5 years. So that after 5 years, you have to give only PPSV 23. And this till the patient reaches the age of 65. Every 5 years. Every 5 years, 65 to 75, clinically we say till 75, after that we don't give. So that is the end for the PPSV 23. So that is one scenario where the patient has not taken any vaccine. Now comes the other scenario in which the patient in our clinical practice, because this PPSV 23 is an old vaccine and it is the most commonly advertised or market wise also, and it is cheaper also. So many times these three categories, patient already takes this thing somewhere and he comes to you. So he has taken PPSV 23, now he comes to you. Now the problem here is that if you now give PCV 13, it will decrease the immune response to PPSV 23. So that is the factor. So that is why generally they say that you have to wait for 1 year, as against 8 weeks in all the category. Here, if he has taken PPSV 23, then you have to give PCV 13 only after 1 year. Because if you give, then you are doing more harm than good. Because it might decrease the immune response to the previously taken vaccine. So that is one of the things because which help is there. So that is why whenever you have taken first PPSV 23, then you have to wait for 1 year and then give PCV 13.
So any questions on this?
So that's slightly confusing, but the situation is 13 was followed by 23 always.
But 13 is mostly for invasive, but PPSV 23 is for
broader
spectrum. But if he gets that, and also if he gets a normal pneumonia, I mean, it can go for invasive, irrespective of that PCV 13, which has only limited strains, which is not covered in PCV 13. He might get an invasive pneumonia, which has decreased the immunity of the patient.
Yeah.
After 1 year, wait for that.
Every 5 years you have to give up to the age of 75.
Is it a standard practice to give both 13 followed by 23?
Now yes, because earlier they used to say only one, but now it is universally recommended to give both of them. And
Pediatricians start giving the PCV 13.
yeah, pediatric group there is like three doses you have to give in the beginning.
Why do you stop after 75?
Because again they say
response may not be there.
Yeah.
As Dr. Rao said, at the immunity level only there is stop.
Yeah.
So tired horse, how much can beat it? So they get rest.
Average life expectancy they are targeting around 80.
So
maybe.
Yeah.
So if they have not taken previously,
even then the
75,
response is very poor.
Is it any benefit in giving?
If they have not taken
At all.
at all, which at the age of 75,
Yes.
yes. So then again he is coming new to me. So patients with above 75 comes, then we give 2 doses. One PCV 13 followed 8 weeks by. After that then 23 and that's it for life. Yeah. Yeah, after 1 year gap. So that is the only thing. Otherwise, this is not complicated.
It was the logic behind that.
Yeah,
More
the logic
important.
is this.
Because I was also confused. Why this is the 1 year?
Yeah.
Even the farmer rep, they will also tell us like, you give after 1 year if you've taken this thing.
Because
do
the
after
company,
5.
the company people themselves are not very clear about the scientific data. They will say
Yeah.
13 is very serious.
I think now
That
it's
is why
very
it
clear
is not
how
like
why
that.
you have to wait.
Yeah, because more about the vaccine efficacy and getting lost if you do the other way around. So 13, then 23, most of the cases, if 23 by any chance he has taken, wait for 1 year, then give this. And also in only one category, like in cancer patients, you need to give 3 doses, again like a pediatric, 13. So that is only one special category because
No, pediatric, I mean, just to explain this, why do you give it in pediatric? Like, in which special, is there any special condition where in the pediatric you give, or it is
now it is in UIP. Now the 3 doses are in the universal program. That is what I told you.
But I thought it might be only because who are not breastfed.
Yeah, after 2017, it has come into universal program. Every child, because I have 2 kids, first one didn't get, but the second one by default we had to give.
Is it a part of a national immunization program? Is going to get into that?
Yeah, and most of the parents will remember it is a costly thing, 10,000 takes.
Getting vaccinated, in case of we still recommend every 5 years.
So, see the recommendation, actually what is the 2 types of recommendation? One start from 19 years to 64. Other is one group before. So till the recommendation is still 5 years actually. After that, specifically if you have any group of like asthmatic child or something, you can give after 5 years, one baby has been 23. So 23 you can give it every 5 years.
You should not combine 2 conjugate vaccines, PCV13 with the mandatory. You should not give it at the same time because both are conjugated vaccines.
Which one? Then the second one?
Meningococcal.
So
So can we give PPSV23 with meningococcal? Is there any?
maybe yes, but see, as far as this PCV13 and PSV23 are there, so they are compatible with all other vaccines. So generally we in fact give influenza along with PCV13 if the new strain is available to make it easier. So we can give the influenza vaccine same day. So one on this side, one on this side, same day. So generally I believe it can be given.
But in CDC it is clearly mentioned.
So meningococcal I am not clear. Yeah, maybe for meningococcal maybe.
What's the adverse effect?
2 conjugate vaccines
You can't
be
give
given
on the
on the
same
same day. So
What is
if you
the-
follow
Immunity
vaccine,
development
What is the time duration?
I'm not sure because it's not mentioned.
Not
That's why
together,
it's
but
clarified.
how far apart? 1 month, 2 months? Meningococcal and the PCV, not sure.
I'm not sure, but it is very clearly given. It should not be
I think
given.
it's a homework for everybody.
Because travel vaccination when we are doing
It's
it,
4
yeah,
weeks.
meningococcal
4 weeks.
4 weeks. Yeah, she's given us 4 weeks. 1 month apart. Right, I think any more questions?
Typhoid vaccine, the new one.
Yeah, everybody's hungry.
Typhoid vaccine, the new one. Is it necessary to give booster?
Typhoid vaccine?
Typhoid vaccine.
The newer typhoid, you're asking if a booster is required.
Yeah.
Not that I am.
There are two, one TCV and
Dr. Gurmeet just clarified it takes group 2 conjugated vaccine. One after 1 year. Dr. Gurmeet clarified.
Sorry, Dr. Belapa.
One Tdap, one Taiba GCV, followed by another after 1 year. 2 doses.
1 year.
Type 1 they say there is no need for booster. Single dose is enough.
Every 3 years. No, now it's changed because the efficacy is better. So they are studying now, like this is the
If you
second
give
year
a
or
booster.
8th year. So the efficacy is good. So they are not recommending now to go for another shot. Typhoid vaccine. Yeah. That's what I got the information from the, like when I was talking to the company, Type 1 TCV company people, they were telling still the efficacy is being studied. And it is still like 70% at 7 years or 8 years after giving the vaccination. So they are saying might not require to go for another booster dose of Type 1. But I'm not sure about the guidelines. This is just an information which I got.
Were you saying the same thing?
Are you saying one more dose of
One more dose after 1 year.
1 year, after 1 year. Especially in children, at 9 months they give 1 dose and 1 year later, at 2 years again 1 more dose. But for adults, I think it's only 1 dose, as what I remember.
Now in children, if you give type 1, again you have to give the same formula?
Same one, after 1 year.
After 1 year. So roughly the age of 2.
Yeah, this brings us to the conclusion of this panel discussion. So in conclusion, opportunistic pulmonary infections can be prevented in comorbid conditions like diabetes. Can you put on the slide, please? Shannon. So with kidney disease, asthma and COPD with significant comorbidity or mortality in these conditions and significant morbidity and hospitalization costs can be prevented by giving pneumococcal and influenza vaccines at appropriate time. Thank you so much.
Thank you, Dr. Siddharth and all the panelists. I would like to invite Dr. V.C. Rao to come on the stage to present the token of appreciation.
Also, I request everyone to come onto the stage for a group picture after this.
Giving AFPA an opportunity to hold this immunization schedule in their premises. I also thank the speakers, Dr. Gurmeet, Dr. Siddharth, Dr. Belliyappa, Dr. Vijaya, Dr. Aarti, Dr. Venkatesh, Dr. Akshaya, Dr. Uma, Dr. Jyotika, Dr. Roshni and Dr. Vaibhav, especially pulmonologist, for an active participation in this CME. And Dr. Shalini, Dr. Jyotika and Dr. Siddharth have put a lot of efforts to organize the CME. I thank you so much for them. And I also thank RxDx marketing team, the head Dr. Sunita Maheshwari, and the IT people, the housekeeping staff, and all the people involved, and not to forget pharma, especially GSK, Pfizer, Mayer and beyond, who have supported this CME to happen. Thank you so much. And this CME had no meaning without the presence of all these actively participating delegates who have come here. Thank you so much. On a Sunday, I love to see this crowd for a physical presence. So AFPI has decided to have physical CMEs half a day once in 2 months, and I would request all of you to come and actively participate to know better. Thank you so much. And not to forget to see you all in Belgavi conference. It's going to be a great delight.